the Highland. We finished last time with hyaline cartilage, so we had talked through several other connective tissues, and we're working our way through an outline that started with fibroblast being the cell type of connective tissue proper, and then we talked about the others: chondroblast for cartilage, osteoblast for bone, hemocytoblast for blood. And so this is the second variety. We just finished the reticular connective tissues, talking about their presence in bone marrow and lymph nodes. And so now we want to talk about the three kinds of cartilage and their location in the body, and a little bit of maybe a little functional information as well. This is a section of hyaline cartilage, and the first impression students get, because they have heard me emphasize it so many times, the first impression students get here is, you told us that we're going to identify the tissues based on the arrangement of the proteins there, and I don't see them. So we might respond to that by saying, well, okay, but we are describing it, it's just the absence here. But that's not what I want to say, because the truth is, the matrix of hyaline cartilage is just as dominated by protein as any of the other connective tissues we've looked at. In addition, the matrix of the hyaline cartilage is dominated by the same protein. So what you don't know, at least from me, are the details of all the varieties of collagen. So this type of collagen that fills the matrix of hyaline cartilage is a slightly different structural collagen compared to the collagen that we find in the tendons and ligaments. But it's there in the matrix. So we can describe the anatomy of hyaline cartilage with the protein collagen. Now, what's really important to me is that you realize the places in the human body where this is so important. So after we leave skin, the next chapter for test 2 is going to be bones. And one of the first things I'm going to teach you in that introduction to bones is where bones come from, how you make them. So certainly, very early on in development, bones are not calcified, which means they don't have the structural integrity that adult bones have. So what are they? And the answer to that question is, well, there are two different things. For skull bones and flat bones, like flat portions of the scapula and the sternum, those bones come from these sheets of fibrous connective tissue. And I'm not going to walk through that process with you in bone development, because you can summarize it easily by saying the bones are formed in a sheet of fibrous connective tissue. The bone-forming cells migrate there during development, and they start laying down the bone. I can summarize it that way. I'll do it the same way when we get to bones. The other type of bone development that we will learn, I will give you a stepwise presentation of the formation of bones, in which we describe how bones arise from cartilage. So, all of the long bones in our body, all of the wrist bones, the carpals and the tarsals of your ankles, and the metacarpals and the metatarsals, and all the 52 phalanges that are present in the human body, all of these bones that have length, the vast majority of the bones in the skeleton, are made from hyaline cartilage models by a process that I will teach you for test 2 called endochondral ossification. So this first line says that the hyaline cartilage forms most of the embryonic skeleton, and that's what that means. In fact, when you're born, there are bones all over your body that have not yet become what we will notice they are in the adult, a completely calcified matrix. Bones that still have cartilage in them. So, for example, a 2-year-old falls off the couch and lands on their wrist. And if you don't look, they jump up and they're playing again. But a 25-year-old jumps off the couch and lands on their wrist, and they have to go get x-rays. And it's likely that they have fractured carpals or bones of the antebrachium. Why? Well, because in the 2-year-old, that cartilage is not yet completely ossified. It's still soft tissue. They have rubber balls in their joints. That's hyaline cartilage. In fact, after the bones are finished forming, after they're done, no more growth going on, the bones are all finished ossifying, you're a 30-year-old adult. The ends of the long bones still have hyaline cartilage on them. The remnants of what used to be the bony model of hyaline cartilage. It looks like that. So you cannot overemphasize the importance of hyaline cartilage in the development of the skeleton. It will be pointed out again to you as we get to the joints that these remnants of hyaline cartilage remain once the bone has finished ossifying. In fact, this doesn't mention it, but when I get done with bone development, I'm going to teach you about long bone growth. And what you're going to see is bones through adolescence and adulthood that are getting longer. You're getting taller. That length increase in the bone is not really a length and increase in bone as much as it is cartilage. That kind of cartilage. As soon as the bone finishes catching the cartilage growth and seals into a purely calcified matrix, there is no more growth. So the growth plates that are in our bones during growth are that stuff, hyaline cartilage. Okay, so you can't overemphasize its importance. This picture shows you the costal cartilages of the ribs. I taught you that bones are joined to bones by ligaments and muscles are joined to bones by tendons. And that tissue looks like dense regular, collagen in these very regular patterns. And so you expect, wherever you go in the skeleton, that bones are joined to bones by dense regular connective tissue. That's fair. However, in this very unusual arrangement, and you're going to see this with the fibrocartilage as well, very unusual arrangements, things that you might not expect, the ribs are actually joined to the sternum by way of hyaline cartilage. Now, what do you know already, because my introduction to connective tissues included this, what do you know that is unique or special about cartilage as compared to other connective tissues? What's different about cartilage? The example that I gave you was an injury to your knees.
It doesn't regrow.
What's that?
It doesn't have blood supply.
Yeah, blood supply. So why is that a problem?
It can't regenerate.
Doesn't regenerate and heal well. Exactly. Okay, so if an individual has to have a heart procedure, something needs to be done to their heart, the surgeon has to get access to it. The heart is protected behind the sternum. The tissues, the costal cartilage tissues, could be cut with scissors. Cut through them. But that's not the way they enter the thoracic cage. They enter the thoracic cage by sawing a hole down the center of the sternum and opening up the thorax that way. Why? Because the cartilage is not going to heal. Exactly. You've created a lifelong problem by cutting that cartilage. But the bone will heal in the procedure. So, very unusual arrangement. There are 12 pairs of ribs. The first 7 ribs that we call the true ribs attach directly by way of hyaline cartilage. The first 7, the true ribs, attach directly to the sternum. Hyaline cartilage junctions. The next 3 are called false ribs because they attach to the sternum, but they do so indirectly. They have to fuse. Their hyaline cartilage fuses with the hyaline cartilage of the 7th rib. The last 2 ribs are called floating false ribs because they don't attach to the sternum at all. These are the only 2 pairs of ribs that have no hyaline cartilage on them. So, costal cartilages of the ribs, important place for hyaline cartilage. Yes, sir? The last two ribs, 11 and 12, are floating false ribs. There are no attachments from those two ribs to the sternum. All right? This hyaline cartilage also makes up the bulk of the mass of your nose and of your trachea and larynx. Okay, so this is important. The trachea is the airway. So what we'll learn in the second semester of this class is that the entire respiratory system is nothing more than a regulator of the air that's coming and going from the functional location, which is the alveoli. So you know the anatomy of the alveoli already. Simple squamous epithelium. The rest of the airway has one job: to regulate the amount of air that goes to the alveoli and gets away from them. That's it. The entire space from the trachea, from the larynx, the voice box, through the trachea, through the primary, secondary, lobar, segmental, respiratory, right down through the chain of bronchi. That is dead airspace. There's no gas exchange taking place. These are areas that have to move the gases back and forth. The reason I bring it up that way is the trachea illustrates this as step one in this regulation. The trachea is, the walls of the trachea are built in the same way that you see a reinforced garden hose constructed. So you can go to Walmart and buy a $5 hose, and it'll last you a few months. But as you get to be older, you realize you might as well pay $20 for the real garden hose. What's the difference in the two? The walls. The walls of the hose are different. They're reinforced walls. And if you look carefully at the hose, I think about this when I look at my garden hose, you can see these little rings around the hose. That's the way the trachea looks. The rings are hyaline cartilage rings. And they don't go all the way around. They're C-shaped. So every human has 20 C-shaped hyaline cartilage rings that support the opening of the trachea. The trachea is really best visualized as a reinforced garden hose. You cannot close it. The trachea stays open all the time, and there is no other regulation there. So it's just an open tube, and it stays open because it's reinforced with hyaline cartilage. Now here's the second regulatory thing. It doesn't have to do with hyaline cartilage, but we'll mention it here. I like to bring up introductory things that you can never forget, right? Asthma patients can tell you about this. The second regulatory thing in the respiratory system is the transition from the hyaline cartilage support to the rest of the airway, the small bronchial tubes. Those tubes have smooth muscle in their walls. So that's coming in the slide. In just a moment, I'm going to say it again. Smooth muscle. And your body regulates the contraction of that smooth muscle to regulate the size of the airway. Now we take advantage of this in clinical settings. If that smooth muscle contracts, the airway closes. And there are certain things that facilitate that happening. Allergens can do this, responses of the immune system. So a person who has some sort of acute hypersensitivity to peanut butter or bee stings, they can have a response where their airway will close up completely. And an immune response that causes that smooth muscle to contract. So in response to that, we give those people, to save their lives, EpiPens. Epinephrine is the chemical that your body uses to open the airway. It is the chemical that your body normally releases onto these smooth muscle cells to cause them to relax and open the airway. So every asthma patient can tell you about these epinephrine drugs. Someone with chronic asthma that carries an inhaler around, there are two drugs in that inhaler. There's an anti-inflammatory, a cortisone-related drug, and there is a drug that binds to the smooth muscle of the airway and makes it relax so that you can breathe. So that's coming You've been introduced to it here. Hyaline cartilage is important in reinforcing the trachea and the voice box, keeping them open. Here's the second kind of cartilage. It is elastic. Elastic cartilage. You learned that there were three major fiber types in connective tissues, and I identified those as collagen protein, elastin protein, and I said you should think of those as the ropes and the rubber bands of connective tissue, and reticular. Those were the three that I introduced to you in the introduction. This is a great example of a tissue that has a high concentration of elastin protein, elastic protein in the matrix. It gives it a different consistency. It makes it more pliable. Is that a good word? Elastic tissue in the elastic cartilage. This is the major support of your external ear and of your epiglottis. Now, I'm going to teach you how to be smart human beings. By the time you're done with anatomy and physiology, it is my goal to change the language of your life. And I'm going to encourage you to do that. Here's how I like to encourage my kids to do this in my classes. I meander around campus from time to time, and your faces now are beginning to look familiar to me, although I don't know very many of you. I would like to know more of you. If I run into you in the Student Center, something I'd like to have an excuse to talk to you. That's something that I would enjoy. Tell me who you are, where you're from. It's going to be hard. There's 70 of you. It's going to be difficult, I know. But I'd like to get to know you better. So I'm going to give you a little encouragement to take the time to say something to me as I pass. Okay? If you and your friends are talking to each other near the bookstore or something, and I walk by, and you call me over, and you can correctly use some anatomy language in your conversation, I'll give you some bonus points for it. Is that encouragement enough for you? So here's one that you can use. I'm going to give you one right now. You can use this with each other. It is the correct terminology. So this little knot right here in your throat is called the larynx. That's your voice box. Its walls are supported by hyaline cartilage. That's true. But there are, in fact, 6 cartilages that support the voice box walls. One of those cartilages is called the epiglottis, and it sticks off the top of your larynx. On the front side of your larynx, it's a little piece of cartilage that sticks straight up. Whenever you swallow, the muscles of your pharynx elevate, pull your larynx superiorly. And as they do, this pliable piece of cartilage called the epiglottis bends over as the larynx moves superiorly, and it closes the airway. It is the lid to your airway. So that when you swallow, things don't go into your lungs, they go into your stomach. This is the function of the epiglottis. So, if, for example, you were standing in the crowd and you're talking to each other and your teacher walks by, one of you could, in a fake way, get choked up. Now, one way to say that is, went down the wrong tube. But the correct way to say that is, excuse me, I didn't get my epiglottis closed. Right? You're laughing, but that's correct, right? Because if you didn't get it closed, you got something in your airway, and you're going to have a gag reflex, a cough reflex, to get it out of your airway. Okay, so encouragement for you to talk to me whenever you see me on campus. Come get your bonus points. Come talk. Come talk to each other about anatomy in front of me. Okay, here's the third type. This is fibrocartilage. This is another one of those things where we say, well, that's unusual. Fibrocartilage helps to make joints, joining bones to bones. And so this section of fibrocartilage here says that it is found in the intervertebral discs. You're learning the bones of the vertebral column, right? Has anybody been able to identify the intervertebral discs in the laboratory? They're not there, are they? This is living tissue that has no calcified matrix. So when it's no longer getting supply, it degenerates. It's gone. So any skeleton that you buy, if you want to illustrate intervertebral disc, you have to buy these vertebral columns that have these felt inserts between the bones to mimic what the fibrocartilage would be. Now these are important for all kinds of reasons. The first thing I'll point out to you is that they're soft tissue. And they're made up of components that they're made up of components that clinicians use language to describe regularly. So each of these pads, each of these fibrocartilage pads between their bones, consist of two major pieces that clinicians refer to. The first piece is a thick fibrous band around the pad called the annulus. The technical term for it is the annulus fibrosus. But in clinical settings, you'll hear it referred to as the annulus. They have a protruding annulus. They have a weakened annulus laterally at L4, L5. That's a very common description right there. A weakened annulus at the L4, L5 junction. Now let's talk about that for just a minute. All of you are interested in clinical settings at some level, right? So when you look at the vertebral column from a lateral view, side view, looking from a lateral view of the vertebral column, you'll notice immediately, even in a normal vertebral column, that the bones of the vertebral column are not lined up vertically. There are curves. Now, these curves can get out of control, and you can create lateral curves like scoliosis. You create lordosis with exaggerated ventrally lumbar curves. You can have kyphosis with dorsally exaggerated thoracic curves. You can get these curves can get weird, true. But in a normal vertebral column, there are curves. So in the cervical region, there's an anterior projecting curve. It curves this way, to the front. Just a slight curve. In the thoracic region, where your ribs are, there's a dorsal curve. So you're standing here, there's a natural curve in the vertebral column this way. In the thoracic region, in the rib cage area, there's a natural curve this way. And in the lumbar region, it turns and goes the other way again. It's anterior, and you can see that in this picture. You see the anterior bulge here? So this is anterior, and this is posterior. So there's a slight anterior curvature in the lumbar region. The reason I point that out is because you've already seen how massive the lumbar bodies are, right, in the lab. They're huge. That's how you tell. It's a lumbar bone. The bodies are big. And the reason they're so big is because they support a lot of weight. If you want a bone to get bigger, you put stress on it. This is a philosophy that changed orthopedics 40, 50 years ago. When my dad broke his arm as a youngster, they put him in a cast and left him there for 6 months. Today, if you break a bone, as soon as the physician can determine that you are not going to further exacerbate the crack or the fracture or whatever in the bone, as soon as it's healed enough so that you're not going to do any further damage to it, they want you to use it. Because pulling on it, putting pressure on it, is going to make it get bigger. When people get bigger, athletes that you see, I used to notice this. You see this guy, Ken Griffey's playing for the Seattle Mariners, and you look at him 15 years later, and he's a massive individual. He's not just bigger muscles. His bones are bigger. So as the muscles grow, the bones grow with them. It's one of the real dangers of really accelerated muscle growth. Bone fractures. So the bones respond to the pressure put on them. That's why these bones are so big. That's a law in orthopedics called Wolff's Law. So this bone stuff is big here. But you can also see that because of the curve of the cord, you're going to be putting a lot of pressure forward here. And that pressure shows itself up more often than any other place in back injuries, right here between L4 and L5 and between L5 and S1. Because that is where the bulk of the upper torso weight is projected. So if you do something weird, you don't use your legs, you pick up something, you put added pressure there, this is where injuries occur. And so the injury, most often, the injury here is weakening the fibrocartilage between those bones. And the pain that results from that is caused by the weakened fibrocartilage protruding into the space where the sensory neuron information is. So you don't know where all this is yet, but you will during this class, this semester. You will learn about these. So the weakened annulus protrudes and impinges. It presses the dorsal root ganglia up against the transverse process. And you know when that happens because your body interprets that as pain. And it projects that information to your brain as pain from where the nerves that come out here actually go. And these are the nerves, these are actually the nerves of the sciatica. So normally it's projected here in the back region, along the buttocks, along the back of the legs. Some projects somewhat lateral, depending if it's L4, and then down the crural region of the leg. So the pain comes from a weakened annulus. The inside part of the fibrocartilage is called the pulp. So sometimes they'll use that clinically. There's a pulp protrusion at L5. There's an annulus protrusion at L5, impinging on the nerve L4 or the nerve L5. And so that's where the pain is coming from. And so it depends. I think there's a neurosurgeon here in town. They told me this one time. I went over to see a stereotactic surgery that he did. I've done a lot of that on rats. Nobody cares if you kill a rat, but if you do stereotactic surgery on a person, people get nervous. And is everything okay, Beth? You leaving us? Okay. You coming back?
Yes, sir.
Okay. So they get very nervous if you do this on a person, stereotactic surgery. But anyway, we were chit-chatting about this, and I said, you know, Doc,